Good afternoon, everybody, and from a very foggy Toronto, welcome to the Center for Practice Excellence Speaker Series. My name is Zubin Austin, and I am the Academic Director for the Center. The objective of the Center is to help enhance the health of patients and communities through the best use of medications, and our mission is to generate and utilize leading-edge medication management research and innovation to drive educational programs and practice that will revolutionize patient care. And that is a very good context for today's presentation, which will focus on medical aid in dying, regulation, and one pharmacist's journey towards understanding how MAiD can and should be implemented. I will turn it over to the administrator for the Center for Practice Excellence to introduce our speaker. Thank you so much for joining us today and enjoy today's very important event. Over to you, Annalise.
Thanks so much, Zubin, and echo your thoughts. I'm very excited to hear from Katrina today about this really important topic and also hear some of our audience members' thoughts. So just before we get started, I just want to provide a land acknowledgement. So I wish to acknowledge this land on which the University of Toronto operates, which is where Zubin and I are located today. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. For my own path to truth and reconciliation, I personally have benefited as a settler from living on this land in Treaty 13 here in Toronto, as well as throughout my education and training on the land in Ottawa and British Columbia. I'm grateful to work towards a deeper understanding of the history that has brought myself and all of us to reside on this land, and also to work towards creating environments of mutual respect and learning. So I'd like to introduce our speaker for today, which is Katrina Mulherin. Katrina is a consultant pharmacist who has performed in rigorous clinical, academic, research, and regulatory roles. Her research interests include arts and media-informed qualitative research, which examine the relationship between professionals and their practice, law and ethics, and transformative learning. Whatever her role, she strives to provide meaningful, challenging, and fun rotations for University of Toronto and Waterloo pharmacy students. Right now, Dr. Mulherin is currently developing programming and research addressing the moral distress experienced by pharmacy professionals in the course of caring for patients. She's consulting for professional organizations, and of course, getting her skis waxed in expectation of snowy trails for this winter. Katrina, we're really lucky to have you with us today. I'll turn it over to you now and feel free to get us started.
Thanks, Annalise. Thanks to Zubin. Thanks to the University of Toronto for seeing the potential in a talk on MAiD. It's a weighty concept. And I think within this audience, although we've got a small one today, we've all had some unique MAiD experiences, whether it's been patients served, colleagues supported, people you've loved or had special relationships with. Any of those types of scenarios can be recognized as intense. And so it's important in these situations that we take care of ourselves. And to that end, I'll invite you to join me in an arrival exercise to settle us for what is to come. And you can stand or sit for this. If you've been sitting all day, I'll encourage you to stand. If you've been standing all day, sit. Whichever you choose, sit or stand evenly balanced, left to right and front to back. Your spine should be erect. Your arms can dangle, or if you're seated, you can place your hands on your thighs, your feet on the floor. And if it feels good to you, go ahead and close your eyes. Exhale, and then on the inhale, open into a spaciousness. On the exhale, find ease. Inhale, spaciousness. Exhale to ease. Once more in, spaciousness, and once more out, ease. I'd like to start us off, and sorry, if your eyes are closed, you can open them. Thank you for joining me in that. And I'd like to start with a poll question to gain a sense of who's in our virtual space with us today. So Annalise, I think you're going to help me with this. Yes? Okay. So if you could answer the question that should be on the screen in front of you. I have had experience with MAiD as a blank. And given the number of people who are here, I think that's probably the expected number of responses. So we've got some clinicians, regulators, and researchers. Thanks, Annalise. Okay. Annalise's territorial acknowledgement is a little bit different than ours here in New Brunswick. Here, we respectfully acknowledge that the land on which we live and work is the traditional unceded territory of the Wolastoqey, Mi'kmaq, and Passamaquoddy peoples. And these peoples would have used the river that you see in this photograph in front of you right now. This is the Nashwaak River, and it's directly adjacent to where I'm seated today. And so our First Nations would have used this river to gain access into the northwestern part of the province of New Brunswick. It's how they would have left the St. John or the Wolastoq River. So why are we here? And I don't mean that generally, I mean, why are we here at this presentation? So I can tell you that I'm here because there was an opportunity that presented a chance for me to revisit my work with MAiD. And when this opportunity came up, I wondered if it would be worthwhile. It would mean me revisiting a time in my life where I experienced quite a lot of uncertainty and stress, but also rapid expansion of my own learning and personal development. It was a significant time to me in many ways. And the work that I did in 2016 is right now beyond its best before date. And it's time to review the regulation that I developed. There are still a couple of unresolved aspects for me in how pharmacy professionals participate or don't participate in MAiD. And so I jumped at this chance from Annalise to have an audience and a conversation in helping me to understand, and maybe all of us to understand why things are the way they are, and maybe see things a little bit differently. But why are you here? And I'm interested in knowing that. If you could write your answer in the chat. I'll just pause for 1 minute for you to consider and reflect why you decided to come today. It's Thursday, it's late in the day, and I'm probably the only thing between you and a really lovely dinner for Thursday night. So feel free to answer now, or you can jot something in the chat if it comes to you in the next 30 minutes or so as I continue with the presentation. And if you're here for the one continuing education unit credit, and it's like no judgment. I'm just going to pause for a minute. Relational autonomy, Peter. I'm not sure of that term. If you care to expand on that, I'd be interested to understand more. So Peter's written interested in relational autonomy of people seeking curable conditions.
If I can add a comment, I'm just reading about this over the last week, and it's the idea is that if you're seeking care from an expert, how can that expert act in your interest? And to do so, they have to have your best interests in mind. And to do so, they have to learn about the person that they're caring for. And so there's a relationship developing. And my question is, how can that relation be maintained? But because I'm a technophile, I'm interested in how technology can be used to help build those relationships.
Okay.
So that the expert knows who they're dealing with.
Okay, I think that is incredibly relevant for a couple of points that I'm going to bring up in future slides. So thank you. Okay, so hopefully everybody's had a chance to input, read each other's comments and hopes. Worldview declarations. Well, thanks to October's CPE speaker, Jared Swidrovich, for presenting. If you haven't seen it, he spoke about contextualizing or personalizing our territorial acknowledgements, like you just heard me do, but also about the indigenization of education or presentations, and that we have to recognize that there are worldviews that are different from the dominant culture in which I'm rooted and in which we find ourselves this very moment at the University of Toronto. The way I think about the world and MAiD is influenced by an atheist, middle-class, colonial upbringing as a female. I've been educated and practiced pharmacy in the Western European system, and these biases that are inherent in my background and your backgrounds are especially relevant in speaking about the topic of death and dying. These were the objectives that came with the advertisement for today: to appreciate the challenges to early MAiD regulatory guidance and to look at future regulatory guidance in the context of recent legislation, societal shifts, research findings, and pharmacy practice models. But I also have some dream outcomes. So for clinicians, I might hope that you'll come away with some reflection on your practice model requirements for safe and high quality MAiD patient services. For researchers, to consider relevant research questions and methods. For regulators, to rationalize future MAiD regulatory guidance via research partnerships. And for educators, to empower students to address their individual moral stance, establish skill in carving their position to provide high quality MAiD service, and also meeting minimum regulatory requirements. So a relevant experience. Well, my undergrad degree was before pharmaceutical care was even a thing. Back then, we were just beginning to dip toes into the process that would eventually be conceptualized as pharmaceutical care. Practice was instead at that time focused more so on the drug product and prescription. And when I emerged in 2009 from my University of Toronto PharmD degree, I had had a conversion of sorts, and that I had seen the light of this pharmaceutical care, later to be called the medication therapy management process. And I practiced in that model in my role as a neonatal intensive care clinician. I was definitely invested, am still invested. I taught my students through it. It was a language I could use with my colleagues and other healthcare professionals. And then when I joined the New Brunswick College of Pharmacists, I used that structure to express regulatory practice guidance as well. So it's helped me organize and scaffold my thinking. Right up until 2016, I was in the NICU at Sunnybrook. We regularly encountered babies who would not live, but it was a little bit different because we didn't purposely bring about their death. It was a passive witnessing or easing. And so while I was at the NICU, I admittedly ignored what was happening with respect to MAiD. I knew that things were happening in Parliament. I knew that it was complex, and I knew that it was not feeling terribly relevant to my work. And so I didn't really follow it. I was curious about the ethics of pharmacists dealing with MAiD in the respective practices, for sure. And then I found myself in 2016 joining the college. And the first thing on my desk that was waiting for me was to write a guidance for MAiD. And so I couldn't ignore it anymore. And so I think that I know the reason I'm here today is really because I wrote that regulatory guidance, as well as some FAQs as a companion document. And having now departed my regulatory position at the college, the work that I did on MAiD leaves me with a strong interest in the topic, and I would expect to be involved in some work at the University of Toronto eventually on MAiD. This is just a screenshot of the first page of the position statement that was authored back in 2016. So that retrospective view, well, my reflections on the third quarter of 2016. As I mentioned, the MAiD regulatory guidance development was on the top of my organization's priorities as I landed back in my home province of New Brunswick that May as the deputy registrar. And it was really a blank slate, this piece of guidance. I was personally brand new to regulation. I had no experience, and I was admittedly ignorant of established regulatory principles, but I knew I had strengths in the roles of clinician, researcher, and educator. And so this piece of work forced me to examine my morals and ethics regarding death and my professional role in providing a means to die and facilitating pharmacy professionals to engage in that activity on a larger scale. As I listened to frontline accounts of MAiD from other countries, the many stories I heard, which were mostly positive, were certainly emotionally charged and required a fair amount of reflection and recovery opportunities, both, I think, for the storyteller, but also for the people who were hearing these stories. I felt the weight of getting this right. And in revisiting for this presentation, some of the scripts that came out of the Senate and the House of Commons, it was pretty evident that they also felt the weight of getting this right. I certainly had a bit of imposter syndrome. And as I worked on this, I was looking for stability, not only of the legislation, but stability in terms of the programs, the clinical programs that were likely to be rolled out. I felt like I was swimming in a wide ocean. And I was constantly looking for some solid land to stand on. But unfortunately, you had to keep swimming because the answers weren't coming in the way that I thought they should or would. And if anything, sometimes I felt like I was being pulled further out from land. So it was uncharted territory. Canada was the 8th country to permit MAiD, and until that legislation, the Canadian legislation, is passed, it remained slippery. It was really difficult to get stakeholder engagement in what was potentially going to be written for guidance because the stakeholders were too busy waiting and watching for the law to be passed. And the provincial healthcare programs were being set up behind the scenes, and no one's interested in sharing because the designers of those programs aren't even sure their Minister of Health, their MLAs, or their civil servants are actually going to approve any of the programs. So it's kind of like chasing your tail. Everyone's in motion, making plans, and then contingency plans in case something doesn't work out. And it actually felt a lot like COVID. At times I felt really alone despite having people around me. But I recognize now that I didn't actually have a regulatory network at that point. So ultimately, I was having to simultaneously develop guidance while struggling with my own emotions and values around death. And as per this photo in 2016 in May, when I wasn't at work, I spent a lot of time in the woods riding my mountain bike, trying to maintain a positive headspace. And it occurred to me, probably because some of the recent work I've been doing on moral distress, that I was probably in a form of moral distress. I thought that pharmacy professionals and their patients would benefit from guidance on this topic, but I also was experiencing constraints and barriers and unknowns and the unintended consequences that would limit my action. This is a photograph of storm clouds on Georgian Bay, and I thought it was apt. So what did I do? Well, number 0, learn how to regulate a profession. And the pro tip, for me is that there's no regulation for dummies. And so I think I read a lot at that point. The stuff from the UK, their Professional Standards Authority, was helpful. And I got to know my own regulation from the New Brunswick College of Pharmacists. I didn't even have that walking into the job. So just that, to understand what previous work had been done, was pretty important. There wouldn't have been much time for much else. So in retrospect, I realized my clinical research abilities were put to good use, just not necessarily so much on a clinical front. So the next thing that I tried to do was describe the problem. And as a good clinician, I started with a literature review. And there were very concrete accounts of ineffectual oral MAiD regimens and reminders that sterile preparation should be used. But most of the literature from it was out of the UK and Europe, sorry, US and Europe, both of which are very different contexts in terms of the permitted regimens. It's also different in terms of their legislative perspective, which, by the way, I realized is why Canada's laws are the way they are, is because the perspective they take in is a patient perspective. And I only figured that out. If you haven't read this book, you might want to pick it up if you're interested in MAiD. The author identifies that that's actually the key to Canada, Stephanie Green, is that it's written from a patient perspective. And then there's also differences in these countries' pharmacy practitioner roles. Normally, in regulation, to describe a problem, we go to medication incident reports and to complaints and discipline reports. But in this case, because MAiD's brand new, those things were useless. What did become evident quite quickly was out of the lay press in Ontario. There were physicians that were refusing to provide services based on individual practitioner-held conscientious objection. And I include a definition taken from a commentary that we developed at the college on conscientious objection. So it's an opinion held by a professional that precludes participation in the delivery of an aspect of patient care. Yes, so the CPSO had two policies: medical assistance in dying and professional obligations and human rights. And so the physician organization, several physician organizations were challenging those two documents on the grounds that they violated the charter. So this raised for me the specter that pharmacy professionals could refuse to care for patients requesting MAiD, but I still had no idea about the likelihood or frequency of conscientious objection claims within the pharmacy profession. Oh, sorry, back up. Didn't mean to go there right yet. Okay, and then I also had a look at the examination or a deep examination of existing pharmacy regulation. So I thought there might be some issue with pharmacists meeting the profession standards of practice, and the technicians to that, for that matter too. But until the details of the program at a provincial level had been established, there wasn't really an ability to precisely determine how professionals might contravene or not fulfill the standards of practice, and by extension, cause patient risk of poor outcome. Okay, the second thing, I had a look at the legislation to understand if there would be some unintended impacts from that. And so through discussions with other healthcare profession regulators in this province and considerable reflection on the federal legislation within the criminal code, I became concerned that any guidance that a regulator published, if not followed, arguably contravened the Criminal Code of Canada. So we needed to be careful not to place practitioners at any extra risk of liability and prosecution through unreasonably prescriptive regulation. So down here, what I just brought up, this is an excerpt from the Criminal Code, and Part 7 states that medical assistance in dying must be provided with reasonable knowledge, care, and skill, and in accordance with any applicable provincial laws, rules, or standards. So anything that looked like or fit the definition of those three concepts, we would want to avoid. And then the other unintended maybe impact of the MAiD section in the criminal code was that the only professionals exempted from the criminal code in terms of leading MAiD were physicians and nurse practitioners. So arguably pharmacists, therefore, would be excluded from identifying drug therapy problem or drug-related problem of the second type within the pharmaceutical process. Now that was jargony. What that means is the type of pharmaceutical care problem that is additional drug therapy required is required to treat a medical condition would be precluded being spoken about by pharmacists to a patient. So it may result in a curtailing of a pharmacist's normal communications with patients. And then the third thing that might be an unintended impact was the lack of clarity in the role of pharmacy technicians. Because the criminal code didn't talk about pharmacy technicians without further guidance, there may be an impact on accepted or standard workflow and responsibility of this professional group. So with this start, I established some important considerations in the analysis of the guidance. And still, even after analyzing all of that, to assure myself as an inexperienced regulator that my concerns and plans were sound and that I wasn't placing my organization at reputational and legal risk, I decided that I needed more information and embarked on a time-limited qualitative project. That's how I recognize it now. Back then, I recognized it as I need to talk to some people who know more than me. So I showed up at any conference where MAiD was on the program and engaged in dialogue at meetings, social events, walks, bike rides, flights. I crashed a meeting of the psychiatry department at the University of British Columbia one morning when I was out there with the hope that maybe the psychiatrist might be able to sort me out. I mean, my thinking around MAiD out. And I vacuumed up anything that pertained to MAiD. And I used conversations to refute, confirm, and refine my analysis of the data. And I can tell you, I reached saturation. I reached it mentally, thematically, intellectually, spiritually. And people started to avoid me at parties. And only then was I ready to craft this regulatory guidance. Oh, yes, sorry, just the attribution of those two excerpts. Okay, so the MAiD regulatory guidance. Whoops, sorry. In 2016, conceptually, as I mentioned, they needed to convey the least weight possible because of the criminal code section that pointed to laws, standards, and rules. It was to signpost other authorities' existing guidance. It was to educate on relevant MAiD legislation. It had to have a currency of about 2 to 5 years. The content avoided therapeutics, and it addressed a couple of thorny aspects of MAiD legislation, and that was limits on the pharmacist-patient communication regarding that drug therapy type that I mentioned, clarify the role of the technician. It would also touch on conscientious objection and how to fulfill professional standards of practice. So the document we produced covered off aspects of practice that we predicted might be problematic. Success. In retrospect, I question whether or not it was needed. Well, maybe, but there's no good evidence to say for sure. Intuitively, we probably went a little far with the FAQs, the frequently asked questions, but I think that risks to patients associated with pharmacy practice would arguably be mitigated if professional practice adhered to the existing standards of practice from NAPRA, legislation, the Code of Ethics, and evidence-based therapeutics. So the documents may have increased burden on pharmacy professionals, but hindsight's 2020. Since 2016, there have been 2 sets of revisions to the criminal code, MAiD section. Due to resource limitations and shifting priorities, the risks of having outdated regulation are evident in that now outdated practice directive. So that's a good lesson. And then after releasing these documents, we rapidly developed a new Code of Ethics and a commentary on conscientious objection. Those were important works that I'm very proud of that were sparked in part because of MAiD. And these pieces of guidance may preclude much of the content in this MAiD specific document that we currently have. Okay, so that's all the past. Our current view, where are we today? Well, as previously mentioned, there's been 2 changes to the criminal code. There's a third expected in 2023, whereby prohibition on mental illness or the suffering from mental illness will be lifted as a sole basis for MAiD. And that could be important to us. I think we're going to have to wait and see, but I wouldn't doubt that that will cause pharmacists pause. So since 2016, we have established each of our own provincial delivery models. So this graphic is from the 3rd annual report on MAiD from Health Canada. It's a 2021 document, so it's fairly recent. So if we compare these models, which has to do with the way in which the drugs are dispensed, New Brunswick, which I've highlighted down there in yellow, is 100%, as is PEI, Newfoundland, pretty much Quebec, Manitoba, and Saskatchewan. 100% provided with out of hospital pharmacies. So 6 out of the 10, and then the other 4 being Nova Scotia, Ontario, Alberta, and BC, have a much more even split with medications being produced out of community as well as hospital pharmacists. So New Brunswick removed the need for community pharmacy, as did these other 6 provinces, to participate. Also, administration, and this is the same across Canada, has been almost entirely via intravenous route, which means the provision of drug is actually outside the technical ability for most community pharmacies. So in New Brunswick specifically, although some of this, I think the drug shortages probably apply equally across Canada, there have been some other things that have come up over the last 5 years. So these drug shortages have been temporary but frequent. In New Brunswick, through my conversations with pharmacists and RHAs, I understand that the drug shortages have resulted in vials being provided to physicians. And I'm speaking about physicians because no nurse practitioners in New Brunswick are actually engaging in the practice. So yeah, physicians will get the vials so that the unused product, the redundant kit, because there's 2 kits always sent out for a MAiD provision, so that the unused product of an unused kit could be returned to stock with minimal concern about microbial contamination or physiochemical degradation. As far as physician patterns, in New Brunswick, some areas have designated specialists, but others have lots of physicians that provide one or a few procedures. Pharmacists in the regional health authorities here say that their staff, their colleagues, are less uncomfortable when they know the physician frequently performs these procedures. And then as far as increased demand goes, New Brunswick, like I think every other province other than Alberta, Alberta stayed pretty stable in terms of the number of MAiD provisions. They're increasing substantially. And so this year in New Brunswick, we're on track to far exceed the number of 204 in 2021. So hospital pharmacies in New Brunswick are expressing concern now regarding their ability to meet this increasing demand for MAiD medications, given the current level of resourcing. And just FYI, it takes about 1.5 hours to produce a MAiD kit. Staff in each facility also have dramatically different rates of participation in MAiD. At the highest I could find, it seems to be about 75%, but even at that high rate of willingness to participate, there are still challenges to providing services. In one region, most of the staff have declined to participate, and there, the provider, the physician, is given the vials and they actually draw the medication up at the pharmacy on a clean work surface. So essentially that pharmacy has transferred their risk from pharmacy to medicine, who do not have standards of practice relating to sterile compounding. The pharmacists I spoke with did not have a sense of why so many of their colleagues had declined involvement in MAiD. We discussed whether it would be good to know and how to best find out if it's conscientious objection, maybe it's confidence and competency levels, or perhaps it's a refusal based on the model of care that precludes their full professional involvement. So getting into that model of care, in New Brunswick, I've highlighted that in yellow here, 25% of patients have receive MAiD in hospital. So that 25% of all patients receiving MAiD likely have had a pharmacist involved in their care. It is possible that palliative care facilities may also have involved a pharmacist. Now, in conversation with my colleagues at the RHAs, they mention hospital developed protocols. And in these protocols, the organization explicitly allows the pharmacist, or doesn't prohibit, it removes responsibility, clinical responsibility from the pharmacist, and states that this is purely a technical duty of the pharmacy, which is not the norm within hospital pharmacy practice, to say the least. So one of my contacts within the RHA also expressed how demoralized they were at no longer being able, at one point, they were actually going out into the community to provide care. But due to these staffing shortages or resource challenges, they are no longer able to provide clinical workups for patients undergoing MAiD outside of the hospital. In 2017, this pharmacist was collaborating with physicians, families, and patients in their homes, right up to and including drug administration. But due to these staffing issues, they had to return to the pharmacy exclusively. The pharmacist expressed that these experiences, previous experiences, had been some of the most meaningful of their professional career. And it was a palpable loss for them to be called back into the pharmacy. So in provinces where hospitals are providing 100% of MAiD services, I wonder or posit that these professionals may not be meeting the standards of practice for pharmacy professionals. I did put this one section of the standards of practice up. It was the obvious one to me that I would have concerns with. There is in section 1 or domain 1 of the standards of practice, I think there's more there, but this one was the most obvious of concern. Now, interestingly, there's a footnote in those standards of practice that almost dilutes the statement. So I'm a little bit at odds with this, in that I find it interesting that it's been a way out has been provided through the standards of practice. So I'm not sure if my concern is reasonable. And so at this point, I'm going to get Annalise to actually bring up a quick set of 3 questions, and maybe you can tell me how you're feeling about this aspect of the standards of practice being potentially contravened. And if you want to raise your hand and open your mic, if you have some thoughts on this, I'd be happy to hear those. Questions one by one. Okay, fair enough. Okay, so the first is indicate your level of agreement with pharmacists must provide patients undergoing MAiD with care that meets the standards of practice. Okay, so we've got 7 responses. Oh, sorry, we must have some more people showing up. That's great. Okay, so everybody's in agreement. Let's have the second one. Indicate your level of agreement with pharmacists must provide patients undergoing MAiD with care that meets the standards of practice. Oh, sorry. Did I just read the same one? Yeah, okay, sorry. Different. That I reread the first one. Okay, indicate your level of agreement with pharmacists and pharmacy technicians are indeed meeting the standards of practice in my jurisdiction when providing MAiD care. Last 10 seconds. Okay, thank you for that. And then let's do the final. MAiD provision is special and should activate a full pharmaceutical care or medication therapy management workup. Okay. Thank you for that. And this question arose because of there's a story in the National Post yesterday just about the normalization of MAiD. If you haven't read it, you might want to take a gander. Okay, thanks, Annalise. Okay, so there's remaining uncertainty regarding MAiD and evidence that would influence upcoming regulation. So if I were still a regulator, I'd be looking at and interested in updating or totally overhauling guidance. What would I be looking at? I'd probably be looking to CIHI or ISMP for medication incidents relating to MAiD. I have requested that. I haven't gotten anything from them yet. I think that Health Canada, if the data was looked at with a vantage point of trends or concerns regarding pharmacy, I think it would be great to get into that information and analyze it. There's nothing in the reports, but they're probably just not looking for this type of information. I would be looking at complaints and discipline. However, I don't anticipate that patients would be around to complain, so I doubt we're going to find anything there. I think there is merit to looking at some de novo qualitative research into the quality of palliative and MAiD pharmacy care within each province. And I'd be looking at the literature. And I can tell you that I've looked and there's nothing except this from just last week from Terry Schindel and colleagues out of Alberta. And it's an excellent paper. It's worth a read. So her research showed that the pharmacist's knowledge of the clinical context and familiarity with the patient through a previous relationship or a current involvement with their care influenced their decision to participate in MAiD, and then how they felt about that participation. Alberta Health Services, interestingly and importantly, provided opportunity for pharmacists to expand their involvement beyond the transactional responsibilities outlined by the AHS policy and procedure. Pharmacists could be involved to varying degrees, including presence at the provision of MAiD. And she found that as confidence grew, pharmacists increasingly collaborated on the clinical aspects of patient care rather than logistics of medication. Also important from this study was the exploration of emotional burden associated with pharmacist involvement in MAiD. The other literature review I performed was subsequent to, again, Jaros Swiderovich's October CPE presentation, where he encouraged us to explore what is known about our topics within an Indigenous context. So my work to understand our Indigenous people's attitude toward MAiD indicates study has been performed on attitudes to death and dying, but nothing in the peer-reviewed literature provided me with information to impart here about MAiD. And so this statement from Tyler White is understandable, given that Indigenous peoples have had harmful experiences with the healthcare system and ongoing challenges to receiving culturally safe and reliable provision of palliative care. Concerns raised by Indigenous and minority groups has thankfully, appropriately, resulted in changes to legislation to give the Minister of Health, Federal Minister of Health, the power to change the pan-Canadian data collection and monitoring regime for MAiD so that it allows for a couple of important data collection points pertaining to race, Indigenous identity and disability, as well as determination of existence of individual or systemic inequality or disadvantages in the context of MAiD. Okay, so enduring uncertainty also means research opportunities. So I've put a few things, I think 5 or 6 research opportunities up, and then I'm going to ask you to see if there's anything that we should be adding there. So the first one was, do patients undergoing MAiD forego comprehensive medication therapy management workups? This was a concern I had in 2016, but as a regulator, I quickly understood that I had to maintain my sights on the minimum standard of care, which are enshrined in legislation, code of ethics, standards of practice. So I think this is like that step up, right? It's like the ideal care. And I think there's a number of research questions that emanate from this, like, can we establish the rates of these workups on MAiD patients? And so if these rates are concerningly low, why? I would wonder if the prescriptive nature of the criminal code results in governments and health authorities setting minimum standards that encourage pharmacy services to perform to that level, that purely technical level. I'm also wondering if palliative care services in Canada, or maybe by province, don't maybe routinely include pharmacists' expertise in the team. I did do a lit search on that. It seems to be about 80%, but it's an old study. The 3rd annual report on MAiD did indicate that 80% of MAiD patients receive palliative care, and 88% of MAiD patients getting MAiD had access. So there may be some patients who may not choose MAiD if their suffering could be adequately relieved through medication or medication adjustments. Now, Australia, interestingly, is on the cusp of enacting MAiD in their states, and they've established a reliable pharmacist presence within their palliative care services. So Australia may, I think, have greater confidence that their patients have had their medication therapy optimized during their palliative care. Oops, well, I meant to do 2. Are patients undergoing MAiD receiving care that meets the profession's standards of practice, both clinical and sterile preparation? We've talked about that in an earlier slide. My 3rd question, are patients at risk of experiencing barriers to accessing MAiD due to lack of pharmacy practitioner participation? So I think in New Brunswick, this idea seems to have some basis. In jurisdiction where provision of service is split between hospitals and community pharmacy, like in Ontario, maybe the risk is low. The research that needs to happen here builds on Terry Schindels, and she looked at the experiences of pharmacists who agreed to participate. We now need to understand the basis for pharmacists and technicians who decide to not participate. And as a sub-question to this, I think we could also wonder, when suffering due to mental illness becomes an accepted basis for MAiD, if pharmacy practitioners will insist on full involvement in the care of patients or claim conscientious objection related to the mental illness piece being the reason for providing MAiD. Are community pharmacies ready for the model to shift out of hospital? What psychological supports are effective for pharmacy practitioners who provide MAiD services? And I think this question is incredibly relevant given the pervasiveness of moral distress, disengagement, and burnout experienced by pharmacy professionals. Given the emotional intensity associated with death and dying, pharmacy organizations and healthcare institutions should really clear the way for sufficient self-care and sharing of the emotional burden. And then I'm going to pause and see if there are other research questions or concerns that I have not covered off today. I'm just looking at the chat. Also, with a small group, we can also unmute and speak too, if that's easier. Yeah.
This is Peter Pennyfather here, and I'm just wondering the role of the health professional in communicating patient experiences or allowing the recipient of MAiD to share their story and their decision-making processes and get them engaged in this examination of the professional roles.
I think it's an excellent question. One of the lines of inquiry that I originally had in the presentation had to do with patients and their expectations and the patients leading the process. And so if they would allow those types of accounts to come forward, I mean, not even just within pharmacy, the meaningfulness within the profession, but it may also activate other healthcare practitioners to call on pharmacists. It would also activate patients to, I think, expect those types of services to be applied to them. My understanding, you right, Peter?
Yes, and also the broader circle of care. The significant others will have different opinions about what the decision of the patient would be, and how to mitigate that moral conflict, I guess, to normalize the process of MAiD. Just if you're going to do research, you could ask those questions.
So I think that's very interesting. So have you thought about the way that you would actually engage patients within that research project?
So what my research is looking at how patients with chronic conditions can document their journey and include that as part of the medical record that can be entered into the chart. Their impressions. Now, given that it's part of the medical record, they as part of their estate, they could volunteer that information, that data, that record could be shared and be studied, either privately from a research perspective or even publicly.
That's fascinating. Really,
so it's about developing that relational autonomy to build a greater perspective amongst the health professionals about different ways that people experience their care journey, as opposed to just, is the blood pressure all right, or the blood sugars levels right?
Yeah, and that doesn't even need to be textual, right? That
No.
Like you could do a recording.
Yeah.
Thank you for sharing that. And if you've got any papers or readings, I'd be very interested in having those, Peter.
Okay, I can send you one.
Okay, so we had a couple of other comments, I think, or did we? What are the common drug therapy problems patients might experience with MAiD underdosing errors with MDs being their own drug? Oh yeah, yeah. So, and I don't know if it's the drug therapy problems with the provision of MAiD, Zubin. I think, it's not complex, but I think it may be that the pharmacist clinically may have some reservation just about whether their palliative care included optimization of a problem that might actually contribute to them finally electing to do MAiD. But by the time they're getting MAiD, it's almost too late, right? Like the decision has been made. And then Annalise has said, is MAiD in the pharmacy curriculum, and how should it be integrated appropriately? Understanding research related to emerging practitioners could supplement the literature on those who want or do not want to engage in MAiD. I would have to defer to an academic on that. I'm not sure where MAiD shows up. I'm just looking at the time. So I'm going to move on to the key messages. I've got 5 that MAiD practice risks, I think, are largely unknown or anecdotal. There is an emerging or potential human resource and supply and demand issues. Research into care models meeting standards of practice may be advisable, and culturally safe and appropriate Indigenous and minority access to MAiD care is under study, and that moral distress happens within regulators too. And if you'd like to get in touch, here is 2 of my emails. And with that, I will finish. Annalise, if you want to offer to take, I don't know if there's any more questions. We only have about 3 or 4 minutes, so.
Yeah, no, thanks so much, Katrina. I appreciate that we got a little bit of discussion in throughout your presentation through those poll questions and then some open-ended questions that you had. There is a question from Tracy in the chat box, which is, what is the role of an ambulatory/family health team pharmacist in providing care to a patient undergoing MAiD?
Based on what we read in the literature, I think it can run the gamut. It could be involving yourself all the way up to and including going into the patient's home or the place where the procedure will be administered. But I think it could be an individual basis too of the patient. But I don't know that we can necessarily state that you must go to the bedside. But it's important that you be comfortable with the assessment and the plan for that patient.
Thanks, Katrina. I don't see anything else in the chat box right now, so maybe I'll just pose or expand on one of the questions you had on the list related to research to close us out for today, and that's just what supports might be in place for pharmacists / other healthcare providers who are providing MAiD. It does strike me as an incredibly potentially tender and vulnerable time on many levels. And so just wondering, to close us out, if you have any thoughts around what you might have seen on the ground in New Brunswick or elsewhere.
Yeah. So I'd say the most commonly thing that I see in the literature and in conversations with my colleagues is that there are debriefs where you come together after the event to discuss, if there's an emotional residue, but also, what technically went well, what may be able to be improved, and how you're going to make it better the next time around. The pharmacists that I've spoken with would say that being able to discuss with their colleagues in the pharmacy is helpful, although they recognize that because they weren't present and intricately involved, they listen, but it may not be as fruitful as with the team that was actually interfacing with the patient. There are other things outside of the organization, outside the debriefs that people are engaging in, and those self-care aspects can run the gamut from, exercise, psychotherapy, group therapy, and it can be really individual what works for that person. There may be limits to the number that somebody can handle safely, emotionally safely. So I think as administrators, we need to understand that maybe somebody could do 1 a month, others may only do 4 a year, depending on how it impacts them.
Yeah, I think that really makes sense to me, just hearing you say that, the importance of sort of reflecting as an individual on what that experience might bring up for you. And then I think it also just speaks to the power and importance of intra and interprofessional collaboration with regards to that debrief aspect you mentioned. So thank you. I think that, yeah.
technicians can't be left out of it, because even though they're, you know, 1 or 2 steps removed, they're still thinking about what is happening. And I guess the other thing I'll say is, like conscientious objection, your recovery strategies, the effectiveness of them can change over time. So what worked 1 month may not work the next month.
Yeah. Thank you so much, Katrina. I think that's a really, I really appreciate closing us out for today on some of those strategies and taking the opportunity to be a bit reflexive in our own practice. On behalf of the Center for Practice Excellence, I'd really like to thank you for providing, you know, a very thought-provoking, but also very heartfelt presentation to our group today. For those of you who are still with us online, thank you for joining, and I hope you know, you could pick up some real pearls from Katrina's wealth of experience. And on behalf of her, I would say, please feel free to reach out. I know she's always interested in having additional conversations. So thank you so much, Katrina.
Thanks for the opportunity. Have a great week, everybody.
Fantastic. Thank you, everyone. And please stay tuned. We have 2 more events for the Center for Practice Excellence to close out 2022. So those will be happening on December 1st on antimicrobial stewardship and December 6th on environmental sustainability. On behalf of the Center for Practice Excellence, thank you and have a wonderful evening.